Good afternoon, everyone. The topic for today's PG activity is thromboelastography. We'll be studying this topic under the following headings, and we'll begin with basics of coagulation. We all know that hemolysis is a normal physiological mechanism in the body. Hemostasis is a normal physiological mechanism in the body to keep the blood in the fluid state, and it involves interaction between platelets, plasma proteins, and blood vessels. Here, it includes primary hemostasis, secondary hemostasis, and fibrinolysis. In primary hemostasis, there is interaction between the platelets and the blood vessel walls to form the platelet plug at the site of injury. In secondary hemostasis, there is interaction between the coagulation factors to form a stable fibrin clot. And in fibrinolysis, there is dissolution of this fibrin clot to form fibrin degradation products with the help of plasmin. So the basic components of thrombus formation are platelet aggregation, clot strengthening, fibrin cross-linking, and fibrinolysis. We'll be studying coagulation cascade in brief. It includes extrinsic pathway, intrinsic pathway, and final common pathway. In the extrinsic pathway is initiated by activation of factor 7, which combines with tissue factor released because of trauma or some tissue injury, which in turn activates factor 10 through extrinsic pathway. The intrinsic pathway is initiated by the activation of factor 12 with the help of high molecular weight kininogen and prekallikrein, followed by the activation of factor 11 and then factor 9, which combines with factor 8 in presence of calcium and phospholipid to activate factor 10 through intrinsic pathway. And then comes the final common pathway. The activation of factor 10, either by extrinsic or intrinsic pathway, marks the beginning of the final common pathway. The activated form of factor 10 combines with factor 5, which in turn converts into thrombin. Thrombin splits fibrinogen, which converts fibrinogen to fibrin monomers, which spontaneously polymerizes in the presence of factor 13 to form cross-linked fibrin clot. It is the first point at which the fibrin clot is formed. There are various tests which are performed routinely in our laboratories to evaluate coagulation disorders. These includes bleeding time, which depends upon the adequate number and function of platelets. Then prothrombin time, which shows overall efficiency of extrinsic clotting system. APTT, that is activated partial thromboplastin time, which shows overall efficiency of intrinsic as well as common pathway. Thrombin time, which depends upon the concentration and reaction of fibrinogen. Various factor assays to measure the individual factor activities, and various platelet function tests. Then coming on to our today's topic. So what is thromboelastography? It is basically a viscoelastic hemostatic assay to see the efficiency of blood coagulation system in our body. In normal simple PT APTT, we are not able to evaluate if how the fibrinolysis is going on in our body or at what speed the fibrin is getting deposited. But through thromboelastography, we'll be able to assess that, and because it measures the interaction between the platelets and the coagulation cascade, and it also assesses the individual components of thrombus formation. There are various indications of thromboelastography, but one basic indication is that it helps us to differentiate whether the bleeding in the patient, and mostly intra-op and ICU patients, the bleeding is because of the trauma or some iatrogenic process, or because of the underlying coagulation disorder. It helps us to differentiate between these two conditions, and because of that, we can avoid unnecessary transfusions in the patient. Like if the disorder is of platelet, then we shouldn't be giving the transfusion of the clotting factors and all. So this can be avoided through this system. It is indicated in traumatic injury, cardiac surgery, liver diseases, sepsis, and other conditions for which the patients are admitted in ICU.
Coming on to the method of analysis, here you can see that this is thromboelastography machine, which comprises of an oscillating cup along with rotatory pin, which is suspended with the help of the torsion wire to the electrical mechanical transducer. Here in this oscillating cup, we have to place 0.36 ml of whole blood, which will eventually clot because of the oscillatory motion at the angle of 4 degree to 45 degree. Once the clot is formed, this clot adheres to this rotatory pin, which will then move in phase with the cup. That is, along with the cup, this pin will move. And then, once the clot is formed, this electrical signal is sent via this torsion wire to the electrical mechanical transducer, and a graphical image is plotted, which will be displayed on the computer screen.
What we receive on the computer is this graphical image, which comprises of 5 parameters, that is R time, K time, alpha angle, maximum amplitude, that is MA, and LY30, that is lysis 30 minutes after maximum amplitude. It shows both the parameters, whether that is coagulation and fibrinolysis in the clotting system. So there are 5 parameters, and it is to be kept in mind that we have to memorize these in the same order, that is R, K, A, M, L. So R time is reaction time, and its normal value is 4 to 8 minutes. Then K time, it tells us about the clot firmness, and its normal value is 1 to 4 minutes. Alpha angle, it tells us about the clot kinetics, and the normal value of it is 47 to 74 degree. Then comes maximum amplitude, that is MA. It tells us about the clot stability. Its normal value is 55 to 73 millimeters. Then is last one is lysis 30 minutes after MA, that is LY30. It tells us about the fibrinolysis, and its normal value is 0 to 8%. So we'll be studying all these parameters one by one in detail. So starting with R time, that is reaction time. You can notice this point. This is the point at which we are placing the blood in the oscillatory cup at this point. And this is the time we are waiting for the blood to get coagulated. This is the point at which the first fibrin clot is formed. So the time elapsed between the placement of the blood till the formation of first fibrin clot is known as R time, that is reaction time. Then comes K time. Yeah, and if R time is elevated, you can say that there is deficiency of clotting factors. Because of this, the R time is getting elevated, and in such patients will be given fresh frozen plasma because it is rich in clotting factors. The next is K time. It is this one, and it is a time taken by the clot to reach the fixed strength of 20 millimeters. So, and it shows about the achievement of the certain clot firmness. We won't be able to comment on this in normal PT and APTT tests of our which we perform routinely. So it tells us about the certain clot firmness, and it depends largely upon the conversion of fibrinogen to fibrin. So if the patient has deficiency of fibrinogen, this K time will get elevated, and in such patients, we will be giving fresh frozen plasma or cryoprecipitate. Cryoprecipitate is the treatment of choice because it is rich in fibrinogen. But if it is not available because of any reason, fresh frozen plasma can also be given in such patients. Next comes alpha angle. It is this angle which is formed. It is also because of the accumulation of the fibrin after conversion from fibrinogen to fibrin. So it shows basically about the speed of fibrin accumulation. So if this angle is low, then we'll be saying that the patient has deficiency of fibrinogen, and in such patients also we'll be giving cryoprecipitate. Then comes maximum amplitude, that is MA, and this is the highest vertical amplitude of this graph. It shows the ultimate strength of fibrin clot, that is overall stability of the clot, because at this point only the fibrin and the platelets, they interact with each other and form a fibrin clot. It largely depends upon platelets, that is 80%. So if this if this amplitude is less in this graph, then we'll be saying that the patient is having thrombocytopenia or they are low on platelets. The treatment in such patients will be platelet transfusion or DDAVP, that is 1D amine, 8D arginine, vasopressin, desmopressin. Then comes LY30, that is lysis 30 minutes after MA. It is basically the percent reduction in the percentage amplitude 30 minutes after the MA, that is the highest vertical amplitude. It measures fibrinolysis. So this is LY30, that is 30 minutes after MA we are measuring that. If this is elevated, then we can say that there is increased fibrinolysis in such patients, and we'll be giving antifibrinolytics like aminocaproic acid and tranexamic acid. So just to revise, R time tells us about the concentration of the soluble clotting factors. K value tells us about majorly about fibrinogen, but to some extent about platelets and clotting factors. Similarly, in the same way, alpha angle tells us about the fibrinogen activity. In and MA, that is maximum amplitude, it tells us about the activity of platelets in the clotting system, and LY30, or in some systems it is seen 60 minutes also. After 60 minutes also it tells us about the fibrinolysis. These are the different thromboelastography tracings seen in different um, coagulation system disorders. This is the TEG, that is thromboelastography tracing in normal hemostasis with normal R value, K time, alpha angle, and maximum amplitude levels. But in this graph, you can see that the R time is elevated here. So it can be because of hemodilution or because of the clotting factor deficiency. Here you can see that compared to this graph, the angle is reduced. Compared to this graph, the alpha angle, it is reduced significantly. So it can be because of the fibrinogen deficiency. Then this one, compared to this normal hemostasis graph, you can see that the maximum amplitude is reduced to much extent. So this can be because of the platelet dysfunction of the platelets and low number of platelets in the patient. Then comes this graph in which the maximum amplitude is also significantly reduced along with increased LY30 level, LY30 value. So it shows the primary fibrinolysis in the patient. Here you can see that the maximum amplitude is significantly increased as compared to the value of maximum amplitude in the normal hemostasis. So here it is a hypercoagulopathy along with increased LY30 value. So here fibrinolysis is also defective. In this last graph, you can see that the MA, that is maximum amplitude value, is significantly high as compared to the normal hemostasis graph. So this is the TEG tracing which is showing thrombosis. So and these are the respective treatments which are to be administered to these patients. One condition which comes regularly in our practice is DIC, that is disseminated intravascular coagulation. Such patients, the TG tracing is, we receive TG tracings in 3 phases, depending upon what is the coagulation status of that patient at that moment. So the 3 phases are hypercoagulable phase, secondary fibrinolysis, and hypocoagulable phase. In hypercoagulable phase, we can notice that the maximum amplitude of this graph is significantly raised. It can be because of the intravascular deposition of fibrin and high value of platelets in the patient. Then comes the secondary fibrinolysis. Here you can see that the consumption of the factors which occurs in TIC has started. Because of that, this maximum amplitude has started reducing. It is also because of the generation of fibrin degradation products which are released in the patient. Then this graph is hypocoagulable, shows hypocoagulability because of the depletion of the coagulation factors and the ongoing bleeding in the patient. There are certain modifications which are there in thromboelastography. One of them is ROTEM, that is rotational thromboelastometry. It is one of the modifications in conventional thromboelastography, which we have studied previously. We have studied that this it was a cup which was rotating in that, but in ROTEM, that is rotational thromboelastometry, the pin which is attached, it rotates and creates the clot. Its benefit is that it has less turnaround time, that is 6 to 11 minutes, and because of that the pre-analytic error also is reduced as compared to the conventional thromboelastography. Another modification is sonoclot. In this, a vertically vibrating probe is inserted into the whole blood, which and the probe movement generates, after the clot formation, the probe movement generates impedance, which generates an electrical signal and will be plotted as a graph, which will be visible on the computer screen.
Coming on to TTAS, that is Total Thrombus Formation Analysis System, it is one of the recent advancements in the field of detection of thrombotic disorders. It is presently used only for research purposes, which is a microchip based system. It observes the time course of thrombus formation in the whole blood, and it comprises of two types of chips, that is AR chip or adenoma chip and PL chip or platelet chip. It is AR chip is coated with collagen and tissue thromboplastin, and it is used for quantitative evaluation of thrombus formation mediated by the activation of both coagulation and platelets, whereas PL chip is coated with collagen, and it is used for the quantitative evaluation of platelet thrombus formation under arterial flow conditions.
There are various advantages as well as disadvantages of thromboelastography. The most important advantage being fast turnaround time, and we are able to study the interaction between plasma, clotting factors, platelets, as well as red cells. It shows us the real time visual display of the evaluation of the clot, and there is reduction in the non-evidence based transfusion and unnecessary transfusion in the patients, and it helps in detection of early detection of the hypercoagulable state in the intra patients. The disadvantage being that it has poor sensitivity for adhesion defects, and these both of these methods, TEG and ROTEM, are yet to be standardized in terms of sample collection, processing, activators, and other modifications. And because of this, it requires rigorous quality assurance standards. And cost being the major problem, it's really expensive, and the preoperative baseline titers for this both of these techniques are not very sensitive for post-op patients. Okay, so I hope I was able to tell everyone. I was able to explain everyone about thromboelastography. So we'll be seeing some of the graphs so that if you are able to answer them. This is case 1. Anyone can answer, right, from the residents. Case 1. Here you can see that this is the TEG tracing, and the R time is 9.2. K 9.2 minutes, K time is 0 minutes, angle alpha angle is 18.69, and maximum amplitude is 7.1, and this is the TEG tracing. So what can be the interpretation? Okay, Khadija.
Maximum amplitude is too low, so it is either due to dysfunction or reduced number of platelets.
As she said, there is decrease rate, there is marginal increase in the clot like R time, and the significant problem over here is reduced maximum amplitude, so it is thrombocytopenia. Okay, next one. Here, this is a TEG tracing which is showing R time 37.8, K time 11.7 minutes, alpha angle 20.1, and maximum amplitude 27.6. So, and this is the tracing. So,
here we can see that the R time and K time are increased as well as maximum amplitude is decreased. So it could be either because of clotting factor deficiency or platelet deficiency.
yes, exactly. This is because of the factor deficiency, because of the elevated R time. So this is the, and also the maximum amplitude is also very less. So because of the platelet disorder also, this is the these are the coagulation system problems. Next, this is the third case. You can see that this is the TEG tracing, which shows R time 5.8, K time 1.2, and alpha angle 73.06, and maximum amplitude 85.03.
Here the maximum amplitude appears to be increased. The
Yes.
normal value is up to 73.
Yeah.
So it could be because of the low number of platelets or hypercoagulation.
Yes. Here you can see that R time is completely normal, that is 5.8. So there is no problem in the clot initiation. There is increased, but the MA, that is maximum amplitude level, is increased. So this can be probably due to increased rate of clot formation, and it shows as and it is the interpretation is hypercoagulable state, probably first stage of DIC. So the take-home message for this is both these techniques, TEG and ROTEM, that is thromboelastography and rotational thromboelastometry, are they significantly reduce the hospital mortality rate and unnecessary transfusion in cardiac, post-surgical, and trauma patients. Careful interpretation of thromboelastogram is an important step in intra-op as well as ICU patients, and RKAML, this you have to memorize. These are few of my references. Thank you.